Hey, what's up guys, it's Matt, and just shooting my video today about my clinical so far this semester. So like I said, I kind of wanted to wait till I got another week or so under my belt. The end of my second week of my summer rotation, my first week of 3 in a row 12s. You know what, it has been absolutely amazing so far. The group of RTs at this hospital, being a smaller facility, they're all very close. A lot of them have been there a long time, and the way they work together with such a small crew, they have to rely on each other, and so they really expect a lot of each other, and they mesh really well. And it's been a really great experience as a student to be with therapists who are like that. We have 3 different instructors for each day of the week that we're there. 2 of them that I know of are regularly the leads and charges of the department. So it's kind of nice because there will be some days that we're with one instructor and the instructors don't stay for the full 12 because they do 6 hours with us, the day side, and they come back and do 6 hours with the night crew. So they usually do their 12 hours together. They come in at like noon or 12:30 and just stay a full 12 hours. That way they do the last 6 hours of our shift with us and the first 6 hours of the night crew shift. But when those other therapists are there, not as instructors but as therapists working, it's kind of nice because they're always willing to take all of us. Sometimes there's 3 of us in the day and 3 at night, so it's kind of cool to basically have instructors there almost all the time, like someone you know you can count on to go with, especially if things are a little crazy. Being such a small group, sometimes it is a burden on a therapist to have to take a student and then try to explain things when you're really short-staffed sometimes. We don't want to put that burden on them. You know, it's not that we're insulted or anything like that, but we just understand that that's how things happen sometimes. So and then we always have our case study to work on too. So anytime there's downtime or a shortage of therapists, we have to do that, as well as we each have to do 2 patient care plans throughout this summer rotation too, and that should be fairly easy. But speaking of the case study, we did already pick a guy for our case study. Really interesting patient, really interesting diagnosis. So I won't really get into that too much right now, but it's really interesting, and I'll probably go about and do that a little later in a future video. So just as far as the stuff I've seen, so in 5 shifts we've seen multiple rapids, we've seen codes, we've spent a lot of time in the ICU, both the medical ICU and the cardiovascular ICU. I got my first ABG first day of this summer rotation actually. Admittedly, it was a pretty easy stick, and I don't mean that in the sense of like rolling vein type stick, but fully sedated patient, young, nice, big, bounding pulse, and not bounding as in it's bounding around on the wrist, but just massive. You could see his pulse through his wrist. So first stick and got it, and then had a couple more opportunities, and so I've started to get comfortable with that and actually doing them on people. That was really fun. And then just a lot of ventilator exposure. So last semester we had our introduction to mechanical ventilation, and now we're touching a lot of vents, and so I've actually been back in my mechanical ventilation book a lot, rereading chapters, and specifically the vent modes I've been seeing most often. So we've seen a lot of AC volume control. We've seen a lot of AC pressure control. We've seen, we actually saw bi-level, which is the Puritan Bennett 840s kind of version of APRV, and that gets kind of weird because our book defines bi-level and APRV as 2 separate things, but then in the APRV section it talks about bi-level on the PB840. One of our instructors told us don't sweat that so much, just make sure we get the more common modes down, because that was a patient who had developed ARDS. So really cool stuff, and not just getting to know the modes, I mean, and that's going to come too, but just the day in and day out stuff too. Like, we're going to do a vent check. So okay, you hit the patient's room, you start checking the vent, and not just knowing all the parameters to check and alarms to check and apnea settings to check, but then the patient assessment that comes with that. So how's the patient look? ET tube size, measurement at the teeth. You can reference that against past charting. Maybe it's moved or something, so you need to note that kind of stuff. How does the circuit look? Is there gunk? The physical assessment of the patient, how do they sound? Are they really coarse, or like, do they have bronchi? Would a suction benefit them at that time? Are they clear and dim? Did they have any fine crackles? I have heard so many breath sounds this semester, or this summer rotation I should say. Last semester I just felt like a lot of people were clear and dim, and I heard some coarseness, and I've heard everything. I even heard my first rail on a patient, and I thought that was really interesting, because when I asked the therapist I was with at that time, I said, I heard I didn't know how to describe it at the time. I was like, he was pretty much clear throughout, but he had this weird almost, and I kind of made the sound that it made. She's like, oh, like a rail? And I'm like, yeah. She's like, yeah, I heard the same thing when she had the patient the day before. So it was really cool that, okay, that's like a confidence boost, because auscultations and defining lung sounds is kind of a challenging thing. But it's all starting to come together, and honestly, it was after this last shift on Wednesday, it really hit me, like towards the end, that this stuff's starting to click. So everything's starting to make sense now, in terms of why we're doing things, what indicates BiPAP for a patient, what indicates certain modes or certain settings to revisit. Sometimes you're the one making an initial setting and then checking, because the doctor may just put an order for BiPAP with nothing specific, so you can kind of put them on an initial, and then you report back to a physician, and he's like, okay, that's good, or change these settings, and then that's your new parameters that you put in orders for. So it's crazy to see how that works, to see patients get better too. To have maybe someone that you saw in an ED who then gets admitted, and then you get to follow them through to discharge. It's all coming together, and I mentioned kind of at the end of my last video about their scope of practice, so therapist scope of practice at this hospital, and what seems to be kind of a common theme is the smaller the facility, the wider the therapist scope of practice is. So a lot of people don't realize how much stuff therapists are covered to do. And that includes things like starting IVs, pushing narcs. So actually I assisted in a bronch, and my instructor was right behind me, and she was like, okay, so and it was a BAL. So as we're pushing it through, but she actually allowed me to hook up the Versed and the fentanyl and push those, and so that was the first time I'd ever done that. So it's been really interesting. Like I said, they start IVs, so not all IVs. It's not like quite like vascular access yet, but in terms of like a lot of other facilities, if a therapist is about to do a bronch, they usually have a nurse come in to run the conscious sedation or start the IVs or something, and here it's all therapist driven as far as the cardiopulmonary stuff is concerned. I've got to see stress tests, both chemical and exercise. I've also learned how to do EKGs, and so that may be very rudimentary to some people who are maybe more familiar in the medical field, or maybe work as a tech or whatever, but here the RTs also do EKGs, particularly in the emergency department. So I did a little, probably 3 or 4 hours down there with the therapist, and it's mostly EKGs, but like I said, we had someone who needed BiPAP. We had a handful of people on nebs. We had a lady go on not quite an hour long neb, but it was like maybe a 20-25 minute long neb. It's just really interesting to see how they do, and then that made me get really comfortable too with EKG lead placement. So whether or not I would ever do that anywhere else I would ever go, I know how to do it now. I understand lead placement, understand what happens when you get artifact and stuff, if the lines are moving too much or a lead comes loose or one of the stickers peels off too much or something. So it's been really interesting. I watched a pulmonologist during a rapid intubation in the ICU take a second and asked a therapist if they would like to try the intubation before he did. The last hospital, I mean, I'd heard of that happening every once in a while if the therapist really knew the physician, but to actually see him start to get the scope kind of planted in there and then go, oh, did you want to try? And so it was really cool to know that they work really closely with their pulmonologist and the intensivist and stuff in the ICU to get to do stuff like that, because we're trained to do it. It's covered under our license. I don't know what else much to say. That it's just been really, really interesting. We just got to extubate a patient that we had to rapid our very first day. So my very first day last week was crazy. It was just non-stop craziness. Particularly the last like 6 hours of the shift was just, there was a lot of treatments that we basically missed because we were with our instructor dealing with a rapid, like 2 different bedside bronchoscopies. And but this week we got to extubate the patient that we had the rapid on last week, and that's really interesting because, like I was saying, you get to see a patient go from trouble to getting better and hopefully leading to a discharge at some point, or at least a downgrade. It really, if you were wondering if you were going to be fulfilled by it, or depending on your reasons for doing it, if it's altruistic or you just want something, a cool job or whatever, but it is really interesting and really fulfilling to see that kind of progression. So yeah, we've got to do all kinds of neat stuff too, TP's trials, and you see the CPAP, you see the progression from being under full ventilatory support to partial support to CPAP to TP's trials to extubation. It's really, really neat. Extubated the post-hearts, so people who are coming out after the cabbage and stuff like that, and that's a pretty rapidly progressive thing. They want those guys extubated fairly quickly, awake, and they want those people up and walking usually fairly quickly. So it's just really, really interesting to see how it all comes together, and just really feeling like I went from just seeing some cool stuff and seeing trauma and doing a lot of neb treatments to really getting hands-on, especially at an ICU. And so we've still done rounds on the floor and done neb treatments and still heard some really cool lung sounds, especially on like the step down units and stuff, where the people who are in ICU or of a higher acuity, you still get a lot of cool stuff. But the ventilated patients and really seeing that stuff, and it's all coming together. If it's not clicking yet, guys, I promise that there will be a point when you're working in clinic and all of a sudden all the lecture that you've sat through and all the tests you've done, it'll all start to come together. And maybe like you, it'll basically make you realize, like, I remember doing this, but I would like to know more or really refresh myself and crack back open some books. So I've especially been back in my mechanical ventilation book and my pharmacology book. I've had those both cracked back open to really re-enlighten myself on those. It's all of those terms and words and drugs and modes and things that you've seen, and maybe you've even passed a test, maybe you even got an A on that test, but you know, studying for the test and then applying it into practice. That's the link, you know, you have to make. And when I'm making those connections, and to make those connections stronger, I'm going and reinforcing that on myself by recovering that material, going back through notes and stuff. So, you know, if you think you're starting to make your connections, but you want to make them stronger, like definitely look back at some of the stuff you've already done and reinforce that stuff. It's definitely beneficial. All right, so that's all I have today about clinicals. It's going great. I'm having a really awesome time. I'm learning a lot. I'm reviewing a lot, and as I just said, I'm making those connections and starting to feel kind of like, okay, this is what it feels like to maybe be a therapist. Looking forward to next semester and maybe making even more connections as we delve deeper into like adult critical care and really get down and deep in mechanical ventilation, especially as we get to some of those advanced modes of mechanical ventilation, the ones that you maybe don't use very often, but you definitely need to know what they're doing to a patient when you do have to use them. So I'm excited about learning more about that. Anyways, guys, I'm gonna stop it here. I hope everyone's having a great summer. If you're in class, stay at it. If you're in clinic like me, have fun and learn as much as you can. Ask lots of questions, of course, particularly if you're clinical instructors. They're so smart, and obviously they volunteered to instruct students in the clinical setting, so you know they usually know their stuff, otherwise they wouldn't get hired to do it. So ask lots of questions and just soak it all in, because this is going to be the stuff that you're going to really rely on, these clinical experiences come time to actually start working. Once you've passed those boards, you've passed those clinical simulations, you're going to step out onto the court, and it's going to be these experiences that help build your confidence to getting out and doing the work. So, all right, guys, hope everyone has a great day and a great summer. More videos will be coming, so stay tuned. Thank you everyone who's been subscribing, the likes and the comments. There's a few other respiratory therapy channels that have popped up and stuff, so we're not alone. We're a growing field, and we're growing some exposure. So thanks so much for all the support, guys, and I will talk to you guys soon.